JAK inhibitors seem to be definitely have a role in biology, and it's the hottest target right now that they're looking for inflammation. And so I think that's the reason. I'm not that excited. I guess I'm excited for as a topical treatment for really moderate to severe or moderate to moderate to severe patients that I can't get 100% clearance with topical steroids, and I'm loath to start on an oral medication or an injectable medication. So if it can fit right into that treatment algorithm right there, in between, maybe like right before light therapy or right after light therapy, or in addition to light therapy, or somewhere on that spectrum where we're considering some sort of additional intervention, I think that would be very helpful. That's an unmet need right there. But and is there a chance that it could work? There's a chance. Why is my optimism guarded? Because there's been no topical medicine is like, the problem with topicals is the penetration effect. It just doesn't. So I know that you're applying to the skin and we're just managing the keratinocytes, but for whatever reason, the skin penetration or the penetration of the drug to get to where it needs to go to is a lot more difficult when you apply it on your skin rather than take it by mouth.
Okay. Okay, you would talk. Would the topical JAK come before the TCIs?
No, I would probably have it the opposite. It'll be TCIs, fail TCIs, then try the topical JAK inhibitor.
And
probably
why is that?
Because the cost will be an issue. That the topical JAK is going to be expensive.
Yep.
And then you still have a lot more safety data with TCIs than you do with a new drug. So you would still take the long-term TCI safety data.
Okay. All right.
At least for the first few years. Now, if the topical JAK ends up being like, wow, superior to TCIs by significant percentage, like more percent, you can get EASI 75 on a bigger percentage of patients significantly, like 10% more patients, then you would rethink that would change the calculus a little bit.
Yeah.
But I guess
yeah. Go ahead. No, go ahead.
No, I guess this reveals my own bias that topical medicines can only get us so far.
Yeah, and that's fine. I appreciate we're asking your opinions, and these are your opinions, so I appreciate where you're coming from. If I've got 10 million moderate patients, though, and let's just say the JAKs come out really strong, so in other words, the data looks really good, and from my understanding, that phase 2 data looks much better than your Eucrisa, and I don't know how it compares to the TCIs, but if it's superior to the TCIs and you don't have the safety issues, assuming that the phase 2 safety profile plays out in phase 3, and you got 10 million people, obviously the steroids are good. Like you said, the unmet need is very low, but let's just say that if things look really good for the topical JAKs, and even if they are costly, you've got restrictions by managed care, but to your point, you can get through those because you got some dedicated people if you think that there's value for that patient, because you're always playing with the toxicity of the steroids. It sounds as though this could be a good opportunity if the clinicals, the phase 3 reads out really positive.
Yeah, I agree with you. I agree with everything you said there.
Okay. All right. Anything beyond the JAK inhibitors that are potentially on the horizon that you think we should even be talking about?
You mean for mild to moderate only? No. For the moderate to severe, there's a bunch others. There's a bunch of others. Yeah.
So I'm only talking about the ones that are competing in that mild to moderate. How about the NK1R antagonist tradipitant? As I understand, it goes all the way from mild to severe, so this does get into the severe, but as I understand it treats the itch only. Is that something that we should be aware of for the mild to moderate, or is that only going to be used in the more severe, in your mind?
That's the other drug. So that's the drug that it really works as an anti-itch medicine. It's going to be used by everyone. It's going to be used as it'll be a big deal if it really works. That remains to be. I don't think the trial data on that has been. I haven't seen it yet. At least it may have come out, but I haven't seen it yet. But that drug, if it really truly is anti-itch, keep it on your radar, because I think that could be a bigger. I think that's going to be a bigger impact than the topical JAK, because a lot of people will use it off-label because there's a lot of itchy people in this country, and we have no therapies for that itch. I know we prescribe antihistamines, but that doesn't treat the underlying problem. We prescribe topical steroids. We also know that doesn't treat the underlying problem. So that could be a bigger deal.
Okay. My guess, I apologize, I don't have this number, but the TCI, we just talked about, the potential if the JAKs come out really clean and very efficacious, even though it's topical. If that were to occur, I can pull up the sales for the TCIs. How much larger of a market, as you think through your patients of okay, my TCIs, this is where I use it now, and if I have a clean JAK that's very efficacious, and again, that's a subjective term, so I know this is high level rough, but how many times the size of the TCI market could that profile of a JAK become?
So that's a little bit harder to. So that depends on how optimistic you are in terms of how well the JAK inhibitor responds. So let's say that let's say we have 10 million moderate patients right now, and having a hard time. I have a hard time no matter what managing them to zero, complete control. Let's say. With only topicals, which is probably, there's some truth to that statement. Then, and the JAK inhibitor comes along and actually gets moderate patients all the way to zero, then they'll take all 10 million instantly. My guess is that JAK inhibitor won't be able to do that. Because it's not Dupixent, it's not oral, it's not, and Dupixent doesn't take, I don't think Dupixent will also take these 10 million to all of them to zero, but maybe more. But let's say you get a Dupixent effect. Let's say you get 80% of those patients, moderate patients, go away, and TCIs right now aren't close to that. I would say they're, 40%, 50%. Then the topical JAK will have a big impact, and will usurp the TCI market share very quickly. Now, again, a pediatric population TCI will be much slower to change, but the adult TCI prescriptions should change quickly. Okay.
Now, as I understand, these JAKs aren't even indicated below 18. I believe that the ones that are oral, one of them is being studied in severe for down to 12. Just by virtue of that limitation in the oral presentations suggests that there's reasons why they're not going down to really low age. Any comments?
Well, that's just a function of the drug approval process here. So your first trial can never be in children. Your first trial has to be in 18 above. And so that's the reason why.
Showing my ignorance, sorry.
No, not at all. It's a great question.
Yeah, let me just stop for a second. I've got some colleagues on the line that probably have a totally different view of the market, meaning that they're from a totally different discipline than I am, and so they may have much different questions than I have. So,
sure.
You guys on?
Hey, I'm here, but you've covered a lot of my questions already.
Nothing?
Yeah, me too. You got everything that I would have asked.
Okay. So the only other thing that I'm asking, and the reason why I ask so much about Eucrisa is because if the JAKs come on or other products that are in this ballpark of high cost, advanced therapy and mild to moderate that's topical, the one challenge that I still have is, if I'm talking about tablets, there's a certain number of tablets with a